So hi, my name is Linda DuPuis Rosen. I'm one of the nurses here at Stanford. And today we're going to go over the bone marrow transplant program. We're going to have a general overview of it and hopefully to help to answer some questions that you may have about the program. And it really is meant to be an overview and to start to reinforce information that you've probably already started hearing about. And we know from the past that people need to hear things 3 or 4 times in order to start to grasp the concepts. And this is a process that we're going to be bringing you through. So in this presentation, we're going to do 2 things. We're going to discuss the autologous transplant, and then we'll also talk about the allogeneic transplant. And I'll explain those a little bit later. So most of you will have been given a binder, a white binder, that gives you a lot of black and white details about what the process is to take you through transplant. But I'm going to give you a little more of the nursing overview and how the day-to-day expectations of what we see patients go through. So first, I'm going to talk about the autologous transplant. And have about 11 different points that we'll discuss. We're going to do the pathway through the transplant, the day-to-day happenings. So first, we're going to talk about preparation of the patient coming into transplant. So this is true for both transplants, the autologous and the allogeneic. So you're going to meet the transplant team. You're going to be assigned a nurse coordinator. And that nurse coordinator has all these pieces of a puzzle that need to come together in order to get you started through this process. So it's not unusual for them to have put this perfect picture together, given you a calendar, and then somebody comes along and takes a piece of the puzzle out, and then they need to take your calendar back, rearrange things, get a new picture going, and give your calendar back. But know that they're working very hard to get you started through this process. Now, there's also going to be an evaluation and the preparation getting assigned to a protocol. You'll meet with a clinical nurse specialist, and they'll do a one-on-one with you to discuss your specific protocol. We have over 50 different active protocols at this point. So that will be another part of the learning process for you. So caregiver support is extremely important. Everybody coming through this process is going to have either a caregiver or a caregiver team. So we want to be able to support them also. And we'll let you know some of the resources available to help you get them through the process, as well as the patient. Some of you will be inpatient, some of you will be outpatient. And we'll let you know as we review the protocol with you. As far as housing goes, the social worker will point you in the direction of where to find housing. And we usually need the patients here within a 50-mile radius. For the autologous transplants, you need to be in the area for 30 days post-transplant. For the allogeneic and the non-myeloablative transplants, you need to be in the area, the 50-mile radius, for 100 days post-transplant. And then everybody coming through this process will be consented. So now, hopefully you're seeing this video before we actually start you through the program. And it's a great opportunity to have some deeper discussions about coping mechanisms. You may have heard the slang of chemo brain, and that's a term used by a lot of patients when they have found that they're very memory is a little bit shorter, a little more difficult to concentrate. So we're actually prompting people to have some deeper conversations at this point before we start the process. We're trying to promote patients to be more proactive. So it's a nice point to meet up with your caregiver and start talking about coping mechanisms. So thinking about the coping of the patient. Are you a patient that maybe it's the fight or flight? Maybe you're the patient that just needs to have everyone else deal with it all. You don't actually want to know the details, and that's your coping. So it's something that the caregiver needs to be aware of. Or maybe you're the type of patient that needs to vent and yell, scream. Caregiver needs to know this. And maybe that caregiver needs to know that you just need to listen to them. They need that opportunity to vent before any action's made. So as caregivers, a lot of times we have a tendency to want to fix the problem. Maybe they just need to vent. So keeping that in mind and having that discussion. And we also need to look at the caregiver's coping mechanisms. So through experiences, through the 25 years that I've been here at Stanford, I've seen a whole array of how they deal with taking patients through this process. And so let me give a couple of extreme examples. There's the one patient that the caregiver comes in and says, I'll do everything for you. You can just sleep all day, relax. So as caregivers, we need to be sure that we're being realistic, and we've actually discussed with the patients ahead of time how we can best take them through this process. So trying not to overdo it, but again, maybe negotiating with the patient before we start and saying, okay, this is reasonable for you to ask me to do this, because as a caregiver, I need to make sure that you're drinking 3 liters of fluid a day. And then I may need to prompt you to, okay, you're a little behind, it's 3 o'clock, you need to drink a little bit more, instead of going in and demanding, okay, you have to drink this then. So what if the patient tells you no? What are you going to do? So things to think about as a caregiver. And then there is an element of loss of control. We're taking you out of your own environment and putting you in our Stanford environment. So we try to involve the patients as much as possible in their care. So make sure that you're communicating with us and letting us know what your needs are. And we've been doing transplants for so long. Technically, we've got a lot of stuff down pat. But the variation comes in when we have the different patients coming through and the different personalities. And you know yourself well, and your caregivers probably know yourself well. So communication is going to be very important in order to take you through this process. And it's a nice reminder to know that this is a process. And I'd love to say everything is black and white, but we know that there is also an art element to this, and that each individual, we try to make the best decision for them at that moment. So let's say it's day -2, and you're getting Cytoxan, and you're nauseated, and I give you some Zofran, works great, and then let's jump ahead. It's day 6, and you're nauseated, and you really want your Zofran, but now the information's changed, and the nausea may be more related to mucositis, and different drugs would be more appropriate for that maybe, or maybe it will be Zofran. But again, we want to gather as much information as we can for that moment to make the best decision for you at that time. So communication is going to be really important, and know that each patient's going to be a little bit different. So there's an element of isolation that comes with this. Again, we've taken you out of your environment and putting you in ours. So it would be good to prepare yourself to figure out things to do, to entertain yourself, to keep yourself distracted going through this process. And then support is critical. So let us know when we need to intervene. There's a lot of support. We have an amazing transplant team, and the chaplains are wonderful, neutral people. When you feel frustrated and you don't want to offend anybody, you can call the chaplain in and just vent. So know if your needs aren't being met, to talk to us, and maybe we can bring resources in to help you with that. So I'll move on to more of the technical things, and we'll talk about the catheter placement. So there's typically no eating or drinking after midnight. The nurse coordinator will let you know when your appointment is to have the catheter placed. A lot of times the catheters are placed here at Stanford up on the 3rd floor in the Cancer Center. And nowadays, we've tried many different catheters through the years, but we found that the catheters that are actually underneath the skin and then into the vessel, this type decreases our risk of infection. And the procedure is actually really well tolerated because they're doing an interventional radiology, which means we have a picture. So we know exactly where the catheter is going. So, so that part is really nice. The procedure from beginning to end typically is about a 4 to 6 hour time from showing up to the point of when you go out. So you definitely need to have somebody with you that day. You won't be able to drive. What we're doing nowadays is not only numbing up the area when they actually put the catheter in, but we also do conscious sedation. So we'll have a couple of drugs to help you through this process, and it seems to work well for our patients tolerating putting the line in. And then when it comes to taking the line out, it will just be a simple procedure as removing the suture and then slowly pulling the line out. And the autologous patients will keep their catheter till around day 30. The allogeneic and the non-myeloablative transplants will keep their catheters until day 100, right around there. And now I'm going to talk a little bit about mobilization. So this has to do with the autologous transplants. So it's important to know to separate the mobilization from the actual transplant process. So let me just remind you, mobilization is where we're going in and we're mobilizing stem cells. We're actually doing that through chemotherapy. So we're giving you chemotherapy. This causes your counts to drop, and then they go down, and we draw labs about 6 days later, watch for the counts start to recover, and then they do this nice recover with the help of Neupogen. And then when it's at a certain level, then we call you to come back into town, and then we harvest your cells. And then we get enough cells to transplant you, usually in a couple weeks. So the apheresis is the department that's going to help you with that, and they'll be coordinating with your local physician about the lab draws and how to take you through this process. And since we're giving you that chemotherapy, your counts will go down, so you will be neutropenic for a little while. So neutropenic means that your white cells are low. It's specifically neutrophils. Neutrophils make up about 60% of your white cells. And those are the ones that do the fighting for you. They do your battles to keep infections away. So if you don't have enough neutrophils, you can't really fight your own battles. So you're at risk. So we want to do some precautions to minimize your risk of infections. So we're going to go ahead and start you on the low microbial diet. And there's plenty of information in the guidebook about what that diet is and how to do it and how to prepare for it. And also we encourage people to meet with the dietitians when you come in and do a one-on-one appointment with them. There's so many questions people have about diet. So the dietitians are here Monday through Friday, 9 to 5. So if you're in-house or around either an inpatient or outpatient, then you can just call to have the dietitian to come around. So we're going to give you the chemotherapy. One of the drugs is worth mentioning. Commonly, Cytoxan is given for the mobilization. So we want to remind people that there's a couple of side effects with that drug that are fairly common. One being nausea, but the medicines that we give to minimize the nausea work really well. The Zofrans are wonderful for that. The other potential side effect is what we call hemorrhagic cystitis. And that basically means a bleeding bladder. So we want to minimize that risk of that bladder bleeding. And we found through the many years, the best thing to do is to hydrate and to have you voiding frequently. So going to the bathroom very often so that that chemotherapy doesn't sit in the bladder and irritate it and cause it to bleed. So important to remember. And that day, we're going to guarantee that you're going often. You may be going every 10 minutes. The drug goes over 2 hours. So once a Lasix, we're going to be giving you Lasix to make sure that you go frequently. So you're going to be going about every 10 minutes. So just be aware of that. And we want to remind people to use some common sense at that point. What we find is that through the years, patients were at risk of falling because the Lasix may have lowered their blood pressure, that if they got out of bed too quickly, they would faint. So you need to be aware that that's a potential side effect of that Lasix that day, so that just all you have to do is common sense, sit on the side of the bed for a moment before you get up. Make sure you're not dizzy or lightheaded. And it's hugely helpful to do this. And then if you're okay, then you can go to the bathroom. But if you're not, then you need to ask for assistance. Very important. You're also going to be getting Neupogen in order to stimulate a lot of the cells so that we can do the harvesting. So know that you're getting double doses of Neupogen. So it's not uncommon for patients to get joint pain when their counts are really recovering and they're getting high. So a lot of times just before the apheresis, when they go for the harvesting, patients are having some joint pain. And most people can just take some extra strength Tylenol and that will take care of the joint pain. When you come to transplant for the autologous, that you're getting the regular doses of the Neupogen, so we don't see the joint pain as much. And we're going to give you that HEPA filter mask that you've seen. So that one's really important, keeping out a lot of microbes and bacteria that we've had issues with. One of the main ones is Aspergillus, and that Aspergillus is something that grows in dirt. So we really don't want you breathing in dirt. So it's important for you to wear that mask properly. And there is a video on YouTube on how to fit and to wear a HEPA filter mask properly, so we encourage everyone to watch that video. So let's talk about transplant. So preparation for that. So between autologous, let me talk about the auto first, the autologous, and that's where you're going to have frozen cells. And then in a minute, I'll talk about the allogeneic. So with the autologous, it is going to be about a 5 or 10 minute infusion. And so what happens is that just prior to the cells showing up, that there's going to be a technician that shows up with a tub where she thaws out the cells, and they thaw them out just before they reinfuse them. And everybody gets pre-medications in order to minimize any allergy reactions. So it's kind of, everybody gets those. You might be a little sleepy that day. And then we go ahead and hang the cells, and they infuse via the pump into the catheter, 5 to 10 minutes. They've been thawed out to room temperature, so you may notice the coldness. So it's not unusual for people to feel a little chilled. We usually put a couple of blankets on you to warm you up just before we get started. And there's also a preservative in those cells called DMSO, and you will have bad breath for a good 24 hours. Just be aware of that, and you can let us know what you think it smells like. So it will be something that will wear off, usually within 24 hours. So no concerns other than people notice that you've had a transplant. And as far as the allogeneic transplants, your cells are typically fresh, so that they will infuse over an hour and a half to maybe 3 hours. And it's typically tolerated like a regular transfusion. We also pre-medicate you, so you may be a little bit sleepy. And then you also, you can be a full match, but you can be a different blood type. So that's kind of interesting later on, that you'll eventually become your donor's blood type. So usually this transplant is tolerated quite well, and it's just an infusion, just like a blood transfusion. So the cells have gone in. So now we're going to wait for engraftment. Well, what does engraftment mean? It means when your counts have recovered. So this will have to do with the autologous and the allogeneic. So there's a lot of responsibilities that are going to fall on the patient and the caregiver, actually, and the staff. And one of the fundamental things is going to be communication. So you guys need to be letting us know how things are going. Some of you will be inpatient. We'll be watching you closely that way. 24 hours, 7 staff, but a lot of you will be going outpatient, and then the caregivers will be taking on a bigger role, and communication is going to be very important. So we're going to be dealing with symptom management. We're going to try to establish a daily routine with you. A lot of things we do to prevent problems. So if you've ever heard the word prophylactic, that we've done this process for so many times that we know problems can pop up. So what we do is we try to prevent them. So we'll let you know the medications like Cipro, which is an antibiotic, that when your counts are too low, when you're neutropenic, then we may very well start Cipro. And the reason behind that is that, I'll backtrack a little bit, just as a reminder, that chemotherapy, how it works is it kills rapidly reproducing cells. And what cells are rapidly reproducing? Stem cells. So that's why we get the effect of the counts going down. But what do stem cells grow up to be? They grow up to be red cells, white cells, and platelets. So now we know that the chemotherapy has affected the stem cells, so we may have to deal with issues of all these 3 things also being low. And then the other thing that's rapidly reproducing cells is hair follicles. That's where you see the hair loss, all right? And then the other area is the gastrointestinal tract. The lining of that is rapidly reproducing cells. So that's where we get into the issues of the sore mouth, epigastric burning, maybe nausea, vomiting, diarrhea, constipation. So again, we'll have to watch out for those issues. And when the counts go low, then knowing that we have all this flora in our GI tract, and then maybe that has broken down, the lining of the GI has broken down a little bit. So we're going to go ahead and give you an antibiotic to kill off some of that flora. So your medications for autologous are pretty straightforward. For allogeneic, it's a long list. As my patient told me today, he takes many pills. And that is one thing we're very mothering about, that we make sure that you know exactly what to take, when to take it. We'll give you lists, we'll give you times. Some patients come up with their own way of keeping track, but we will be very thorough about that. So there should be no fears about the medications, that we're going to be very thorough. And medications for the allogeneics, a lot of times the dosings are changing depending on blood levels for certain drugs. So again, we'll let you know as we go along. And then it's important that the caregiver also knows your medications well. And not just the caregiver, but the caregiver and the patient. So if there's ever any issues, once you're outpatient, make sure that you call to clarify, especially with medications. So I'm going to talk a little bit. I talked about the counts going low. Stem cells have been killed off. We're waiting for the new stem cells to start growing. So in the meantime, your red cells may be low, so you may be anemic. And the guidebook is very thorough about what it looks like when you're anemic. So make sure that you know that section really well. And just to know, if your hemoglobin is less than 8, we're going to transfuse you. We'll usually give you 1 unit of blood, and that will help. A lot of times fatigue is related to counts being a little bit low, so a unit can help you out a little bit for the energy. And when I mention fatigue, I should also say that that is the #1 symptom post-transplant. And we want patients to be realistic about that. It's not uncommon for people to go for months post-transplant for autologous to still feel fatigued, even though the counts have recovered. And for the allogeneic, it can be 6 months, it can be a year. So we want you to be aware of that fatigue being a side effect, #1 side effect post-transplant, and that there's many times that we need to intervene a little bit, maybe even help patients with antidepressants just to get over that hump. So again, communication is going to be important, kind of being self-aware, or the caregivers can actually notice, maybe there's a trend there that the patient seems like they're getting a little frustrated and depressed, and let us know if we can help out with that. So platelets. Platelets may be low. And what do platelets do? Platelets stop bleeding. So again, in the guidebook, it's very thorough, all the things that you need to do to minimize your risk of bleeding. When you have a low platelet count, that's called thrombocytopenia. And look at your guidebook. And then let me just remind you on some of the more important ones is if your platelet count is less than 10 or 10,000, we'll usually give you platelets. And then if you have any active bleeding going on, we'll look to see if you also need a transfusion. But the things you can do, this is an area where prevention is real important. There's no straight razors used. There's no dental floss. If you blow your nose really hard and you've got a low platelet count, you're really at risk if your platelet count's less than 50,000. So nosebleeds, it's hard to stop the bleeding once it gets going. If you rub your eyes, they can bruise. Making sure that I've had several patients tell me that they've fallen because they were walking across the floor with socks and they slipped. So common sense, if you're walking around, make sure that you have traction on your feet. We also remind patients not to take anything over the counter unless they've cleared it with us. Things like aspirin, Motrin, ibuprofen. Those can thin the blood, so we don't want the patients taking those unless we've okayed it. So now let's talk a little bit about infection. Actually, we'll talk a lot about infection. So the counts have gone low. For the autologous, your counts are down. What I'll typically see, again, I'm generalizing, everybody's going to be a little bit different. but I'll see maybe that their white cell count goes low around day plus 3, day plus 4, and then by day plus 9, they start to feel a little better. And day plus 10, they feel a little better, and the counts start showing. And then day plus 11 and 12, they're really feeling hugely better. So, and then their counts have recovered. If you're in-house, then we'll discharge you. You come out to the outpatient setting. You show up the next day. We make sure you're eating and drinking well, saying, okay, you're doing great. Your plate count needs to come up a little higher. Take a couple of days off. Come back. Maybe you're now at the point of day 18, day 20. You're looking really well. We may even pull that catheter around that time. So depending on how your counts are going, everyone's a little different. And then you're still staying in the area till day 30. We'll make sure that you have a clinic appointment, and then we'll let you know what your schedule is once that line gets pulled. Okay, so the allogeneics and the non-myeloablatives, so we keep you guys around until day 100. So you're going to keep your catheter till day 100. So again, but all of you, you're all at risk when your counts are down, you're at risk of infection. So I mentioned earlier about wearing the HEPA filter mask. You're going to be doing that at the appropriate times, and the guidebook explains that. You're going to use common sense. Stay away from sick people. Young children, we don't always know what they're exposed to, so we kind of minimize exposures to that. If you have young children, then talk to your nurse coordinator, and she'll tell you come up with a plan to allow you to visit with your children. The biggest thing you can do to minimize your risk of infection would be hand washing. And you probably guessed that. So very important. We're usually telling people that a minimum of like 20 to 30 seconds. And a lot of patients, if they'll sing happy birthday while they're washing their hands to make sure that they're doing it long enough. A lot of people don't wash long enough. So it might even be a good idea to practice that a little bit to see if you can sing happy birthday and wash your hands the whole time. And actually for 20 to 30 seconds, it would be happy birthday twice. So keep that in mind. So the other thing that we'll ask patients is to shower daily. And then taking care, we do see a lot of diarrhea. So making sure that the skin does not break down there and taking good care of it. So we're going to be watching everybody when they're neutropenic to see if they get fevers. So sometimes that's the only indicator that there's an infection going on. So everybody should be very clear about what justifies a fever. And it's in the binder at the bottom. There's a whole section on infection prevention, and it says, okay, if the temperature is 101 point, I can't remember if it's 3 or 4, that you call the doctor. Or if you have, 2 readings 2 hours apart of a low-grade fever, then you need to call us. We never know what type of infection gets a hold of you. So we need to take every temperature seriously. Some infections are maybe not a big deal. Some infections can be life-threatening. So some infections can make people's blood pressures just go down very quickly. So we never play around with this. If a patient has a fever at 5 in the morning and has an appointment at 7, they still need to call us at 5 in the morning and let us decide what to do. They need to not just wait till 7. And this is where the caregivers can kind of override the patient. It's like, don't worry about inconveniencing anyone. The caregiver, whoever, needs to call us and let us make that decision, because this is an important thing. So the other thing I mentioned about the gastrointestinal tract. So we need to see if there's any issues going on there. The most common pain that we hear about with our patients is mucositis. And that's where the upper part, we have some breakdown of the mucosa in the upper, maybe in the mouth and the throat, epigastric burning. So we have, as a nurse, I have all these different pain medications that I can try to get that pain under control. So typically, a patient, if you remember the scale of 0 to 10 for measuring pain, a lot of times I can get patients' pain level into a 2 or 3, to where it's tolerable. I can't have you sleeping through the whole process, but we can definitely try different meds to get this tolerable if you're having the mucositis and the pain. The other side effect that we need to watch out for is bladder irritation, some of the chemotherapies can, I mentioned Cytoxan earlier, so it's going to be important if you let us, if you have any bleeding in the bladder, it just takes a little bit of blood when you go to the bathroom to make the urine a little pink, so you need to let us know about that. As far as nausea, vomiting, as a nurse, I'll have several different medicines that I could maybe give you. So I might come back and ask you what you want. And it's not that I don't know what to give, but I need to assess the moment to see what is the most appropriate anti-nausea medicine at that moment. Whereas Zofran might have worked really well on day -2, but maybe Compazine or Benadryl would be more appropriate on day +6. So again, communication is going to be important. And we know that with the GI, the gastrointestinal tract being affected, the gastric motility tends to slow down. So things don't move through very well. And then I see a lot of patients having a lot of secretions. So you know when you get a cold that you just have a lot of stuff there. So if you're building up extra secretions and gastric motility, it's not moving through quickly, then you can see how people wake up a lot of times in the morning and just feel nauseated because things haven't been moving through. So it's going to be important to like small meals, nothing really heavy. You're going to stay away from spicy foods, fatty foods, and drinking and thinning out those secretions are going to be helpful. Let us know if you have diarrhea or constipation, and we need to deal with both of those. Both of those are important to know about. So as a reminder, when you are admitted to E1, if you're going in-house for a while, then it's important that everybody actually call in the morning, and we can let you know when we have a bed open for you so that you don't come too early. So that's going to be important, and it's in the guidebook, the telephone number to call. And then we'll let you know what time to come in at. And as far as discharges go, it's important that caregivers show up a day or two prior to discharge, and we should know like a week ahead of time when the patient's going to be discharged. But we want to review things. So again, most people need to hear things 3 or 4 times for it to really sink in. So maybe you've heard a lot of this stuff already, but we're just trying to reinforce it and to remind it with people that they are very clear, have a clear picture of the expectations and what to do. And then once you come to the outpatient setting, so it's going to be important to be there at the appropriate time, and it's going to be typically a visit is about 3 hours. So we try to get you in and out as quickly as possible, but no, it's just a process of you come in, we seat you, we draw your labs, we wait for results, we see that your magnesium's low, we need to give you a replacement, that takes an hour, maybe 2. So the typical visit's about 3 hours. It can be longer if you're needing blood transfusions or platelets, but know that that's about the length of stay. And making sure, especially with the allogeneic transplants, that we have a telephone number to get a hold of you. What happens with the allos is that we're drawing your immunosuppressive drug levels. And we have to draw that prior to you taking your drug in the morning. And you'll hear this many times from us, so we'll be very clear about it. You don't take your medicine in the morning, you bring it in, just your immunosuppressive drug. The rest of them are usually okay. It's just that one. So you show up, we draw your labs, then you can take your medication for the morning dose, and then we'll let you know if that dose needs to be adjusted because we're following it very closely and we want it in a certain range. So people absorb it differently, and different medications affect it. So we might be just steady, and then all of a sudden we've added a new medicine, and now your levels are really high. So we're watching that very closely. So making sure that we have a number to get a hold of you. And when you show up, the nurse will see you, the nurse practitioner or physician assistant will see you. The physicians rotate through monthly, so they'll also be around. And then the dietitian is around, and we have many resources. So make sure that you, if you have any needs, again, let us know, and we'll try to get the appropriate person to you. Everybody will typically have an x-ray done once every 2 weeks. This falls in that category of catching things early and not waiting for things to manifest full-blown, so that we've found And it's paid off many times that doing a chest x-ray every 2 weeks, we're able to catch things early and then treat. So make sure when you come to your outpatient visits that you bring your medication lists, necessary medications, and then most people will pack a lunch, bring food to eat. We just have juices and crackers, so it's going to be important that you bring in something to eat so you don't get too far behind. And then I also, for the allogeneic transplants, I want to talk a little bit about the graft versus host disease. Now for the allogeneic and the non-myeloablative patients, I'm going to talk a little bit about graft versus host disease. This does not have anything to do with the autologous. So you could stop watching the video now if you'd like. But for the allogeneics, non-myeloablatives, this is when you get cells from someone else, we're going to be watching out for graft versus host disease. So what graft versus host disease is an immune reaction of the donor cells against the recipient cells. And what that really is saying is that it's really the donor cells are kind of attacking the patient. So it can be mild to life-threatening. Now I say that through the 25 years of being here, that I've seen a lot of the lower mild graft versus host disease. We grade it from grade 1 to grade 4. And I see a lot of grade 1s and grade 2s. What I'll typically see is when the patient reaches the day 20 and around there, the counts will typically start recovering at that point. And all of a sudden the patient develops a rash on their shoulders. And the doctors look at it and they're like, and they prescribe this medicine and maybe change this, and then the rash is under control and it resolves. So typically very easy to deal with the grade 1s and grade 2s, and we have many more medicines nowadays to help us with that. I don't see very much at all of the grade 3s or the grade 4s, which are the more life-threatening. And what I'm talking about right now is the acute graft versus host disease. And there actually is another video that will talk about the chronic graft versus host disease. So I'm just going to stick with the acute. And how that usually presents is either a rash or diarrhea or the liver being affected, where you might see yellowing of the eyes, liver function tests go up. And the onset for that to manifest is, they say day 10 to day 90, but usually you have to have white cells to have graft versus host disease. So maybe it's day 6 and you get a rash. It's probably not going to be graft versus host disease. You haven't engrafted at this point. But it's day 21 and you get a new rash, then it may be. And we'll pursue that and treat appropriately. So there's a couple of strategies, there's many strategies to help minimize the risk of graft versus host disease. So there's the HLA matching, which most of you probably know about. And then there is the immunosuppressive drugs. It would be very important to take those at the prescribed times. And that's the one that we watch really closely and do the blood levels. And we draw your labs first, then we do, then you can take your medicine. And what are we doing? What does immunosuppressant mean? It's like these medicines basically keep the white count, the white cells. I like to think of it as a little sleepy, just a little sleepy, so that they don't wake up and see you as foreign and attack. So we want to keep them suppressed, and they eventually get used to their new home and accept you and engraft, and things go on and no problems. But we really want to not wake up those white cells quickly. So what else can wake up white cells? Infection. So if we want to minimize your risk of infections through this process, so we don't really wake up those white cells. So it's going to be important to follow our guidelines to minimize that risk. And another strategy is avoiding the sun. Why is that one in there? To help minimize graft versus host disease. Well, if you think about it, we've given you these treatments, and most of you will be very sensitive to the sun and burn very easily. If you get a sunburn, then you're going to have to heal. You're going to have to wake up some white cells to heal. So you can see how one can lead to another. Now, granted, if you get sunburn or if you get an infection, doesn't mean that you'll get graft versus host disease, but it does put you at risk. So we want to minimize those risks. And I guess one of the other parts that I didn't talk about earlier would be activity, physical therapy. When you're in-house on E1, the physical therapist will be working with you to making sure that you're not sitting in bed all day and moving around. And then caregivers for the outpatients, it will be important that the patient is not lying in bed all day. And again, talk to them and be reasonable about it. Maybe they need a nap or two during the day, but we really want to keep people in a cycle where they're sitting up, moving around during the daytime and sleeping at night. So making sure that you're helping them with that. Moving around, isometric exercises. Again, you can get a physical therapist to talk to you about what that means, what that entails. You know, if you're a marathon runner and you think you're going to be able to do a 10K, probably not going to happen. So we need to set realistic goals for going through this and what is doable. And speaking of that, it's a nice reminder that we tell patients often to have a dual vision. And that vision is to keep in mind maybe what like a year looks like from now. What does a year away look like? Keeping that vision in mind. And then the other vision we're asking for is to focus on the day. One day. Most people, one day is doable. It can seem very overwhelming if you are trying to take it all in. But if you focus on a day and your task, like, okay, I'm gonna get my mouth care in, I'm gonna do 2 walks for 10 minutes, and I'm gonna try to accomplish this. Okay, that's doable. Or I wasn't able to accomplish that, but I'll try a new set of goals for the next day. Then it may keep the process easier. So again, it's a process. We're trying to prompt patients to be more proactive in their care and to have a really good baseline when they come into this transplant so that they feel a little more reassured. There's still a lot of unknowns going through it, but you can have the reassurance that we've been taking patients through this for many, many years. We have the reunion of the allogeneic transplants, actually all the patients. Once you're a year old, then we invite you to come back to the reunion and to celebrate life. And that is the end of the presentation.